AETCM, the emergency medicine channel. Today we are presenting RUSH protocol. RUSH protocol is rapid ultrasound in shock and hypotension. It is a bedside ultrasound which can be used in shock for detecting the cause and for the treatment of the shock.
So that is a word meaning, rapid ultrasound in hypotension and shock, RUSH protocol. Okay. So why do we need to do this in ER?
For a rapid detection of the cause of shock and correction of shock.
Yeah. Not only in shock, in case of any hypotension or in case of any tachypnea or tachycardia, we can do this. Okay.
So RUSH protocol is mainly we are checking three things, that is a pump, that is a heart, and tank, that is IVC. The fullness of the tank is seen by IVC and the emptiness by EFAS, that is any bleeding in the peritoneal cavity, and the pipes we are looking is IVC, leaking pipes is IVT and blocked pipe is DVT.
Okay. So if you are having difficulty in remembering it as pump, tank, pipes and all, how will you remember?
We can like high map.
Can you just mention about that?
High map is like first H is for heart, and that is the parasternal long axis view and the apical 4-chamber view. I is IVC, M is Morrison pouch, that is hepatorenal pouch, and then aorta and pulmonary, or that is pneumothorax.
Okay. So actually there is something else, we can remember it as high mapped, MAPED. So this is heart, IVC, Morrison's pouch, aorta, then pulmonary evaluation. This is ectopic pregnancy and DVT. So we can remember high mapped.
This is where we keep the probes for the for the high mapped. So first is parasternal long axis view. That is, we will keep the probe, that cardiac probe, in second intercostal space, left side near to sternum, and the pointer should be pointed towards the right shoulder, and we can just glide down from the second intercostal space where we get the view. And second is the apical 4-chamber view, that we will keep the pointer in the, first we have to find out the apex, and after that we have to keep the pointer 90 degrees to the right side, and then with either to the left lateral position or leaning forward position we can see the apical 4-chamber view. And third is the this thing, inferior vena cava view. Inferior vena cava view. For that we will keep the pointer towards the head end. And fourth is the Morrison pouch, that we can use curvilinear probe, that is we have to see the hepatorenal pouch, and fifth splenorenal pouch, and seventh is for sixth is for the bladder view, that is we will show do it fast, and then seventh is the aortic view. We can either view as a short axis or longitudinal, and 8 and 9 is the pneumothorax, to see the pneumothorax, that we usually use with the linear probe.
A linear probe with the pointer
towards the head end. So this is a first parasternal long axis view.
So when you describe about each slides, you just mention about the probe direction that also.
Okay. So parasternal long axis view, we will keep the probe in the left second intercostal space near to the sternum with a pointer pointing towards the right shoulder, and we can glide from the second intercostal space to down for the good view. So in this we can, this is the left atrium, this is the left atrium, this is the left ventricle, this is the right ventricular outflow tract, and this is the left ventricular outflow tract or aorta.
And here you can see the valves also, the mitral valve and also the aortic valve also. Okay.
So this view we can see pericardial effusion, and if there is left sidal pleural effusion we can see that, and we will see the alveolar contractility, that is we can see whether all walls are contracting equally, and the RV size also we can see here. This is the RV size we can assess.
But only a little part of RV can be seen here, and pericardial effusion, how will the pericardial effusion look like?
Pericardial effusion, it will be a fluid, black colored, here we can see the black color.
This area you will be able to see this black color thing. Okay.
This is the parasternal short axis view. This is like we will keep the parasternal short axis, that we can same view, and then we can keep the probe towards the left shoulder.
Probe is directing to the opposite shoulder.
Same side, probe towards the left shoulder. So this is the left ventricle we can see. So here the walls are like, this is septal, anterior, lateral and inferior. So if there is any RWMA, any regional wall motion abnormality, we can see by this way, and we can know which wall is not moving.
And you can see the contraction. If everything is coming approximating properly, then that means it is a good LV function. Okay.
And this is the apical 4-chamber view. This is where we will first feel the apex, and then we will keep the cardiac probe with the dot towards the 90 degrees to the left side. So here we can see all 4 chambers. This is RV, RA, LV, LA. And in this view also we can see whether RV, right atrium or right ventricle is enlarged as if in pulmonary embolism, and a pericardial effusion can also be seen in between here, right around the heart.
Okay, so what all things will be seen in pulmonary embolism? If we want to see any RA, RV dilatation, that can be seen. Anything else that can be seen? We can also see one McConnell sign. Any idea what is McConnell sign?
D sign.
That is actually a dip because of the RV collapse. In case of pulmonary embolism, we can see a McConnell sign in the tip of in the apex of the right ventricle. One dip can be seen. Okay. So it will be looking like there is a dip in the wall of the RV. Okay.
And this is a subcostal view, that is we can at the for checking at the IVC side we can see the subcostal view. Here also we can clearly see if there is any.
So
pericardial
how will you
effusion.
scope? How will you keep the probe?
The Syphilis probe, cardiac probe can be kept at the Syphilis sternum, like scooping in, and also the tip should be, the dot should be towards the head end.
Okay.
So this is a pericardial effusion we can see here. And
as I told about McConnell's, can you show the plaques view, long axis view, parasternal long axis? So in this long axis view, and if the patient is having a pulmonary embolism, we can also see D sign. Here we will see the D sign. Here we will be able to see the RV collapse can be seen, that is D sign.
Yes.
And in the 4-chamber view only we will be able to see the McConnell sign. We can see for the pericardial effusion can be seen, any features of RA-RV dilatation can be seen, and also LV functions can be seen. How will you check the LV function?
Contractility we can see, and ejection fraction.
How can we find the ejection fraction? So endpoint septal separation can be checked. Endpoint septal separation, that is EPSS. So if you are keeping in this parasternal long axis view, and we have a pointer in our machine, so you keep the pointer onto the mitral valve, and how much mitral valve is deflecting, that it will be checking. So keep the pointer on the mitral valve and keep it in M mode. So in that M mode you will be able to see waves like this. That is actually the movement of the mitral valve. So if the mitral valve is moving more than 10 millimeter, then that means it is good LV function. And if it is moving less than 7 millimeter, then that means it is ejection fraction is less. Okay. That is endpoint septal separation.
And coming to IVC also seen in the subcostal view, that we will see the IVC with the pointer towards the head and in a scooping position. So we have to see the opening of the IVC from the right atrium, and also we have to see the hepatic vein joining the IVC.
Here it will be joining like this. Okay.
So by looking IVC, it is like we have to measure the
How will you differentiate between IVC and aorta?
Aorta will be, one is this hepatic vein joining, and aorta will be pulsating, and IVC is having collapsibility with the respiration.
Variation. Another thing is that aorta will be having, we can see the spine shadows near the aorta. And aorta will be having that celiac artery opening also might be seen in aorta. And based on the thickness of the wall, we can find whether it is aorta or IVC. Okay.
So we will have to measure the breadth of the IVC.
Where will you measure the breadth of the IVC?
1 centimeter from the opening of the hepatic vein.
Here or here? Here. Here we will have to check the IVC size. Okay.
So if it is more than 2.1 centimeter with less than 50% of collapsibility, it means there is the IVC is almost full. That is there is fluid in the intravascular volume. So, and if it is opposite, that is less than 2.1 centimeter with more than 50% collapsibility, that it is low central venous pressure, that we can give fluids.
Okay. How will you calculate the IVC collapsibility index?
The maximum breadth with the minimum breadth.
That is IVC collapsibility index we will be calculating as IVC's maximum minus IVC during inspiration divided by IVC's maximum into 100. Okay. So if the IVC maximum was 2 centimeter and it is collapsed to 1 centimeter and maximum is 2 centimeter, then
half.
it will be
1/2
into 100. So that means 50%. So we need to use this formula to calculate the collapsibility. Okay.
And this is the Morrison pouch, that is right upper quadrant, left upper quadrant and pelvic. This is, we have to see the free fluid in the hepatorenal pouch, splenorenal pouch.
So we need to use what probe?
We have to use the curvilinear abdominal probe
With the pointer?
pointed towards the head end.
Okay. So this is the liver and we can see the kidney, and where you will be able to see this properly?
In between.
No. Where will you keep the probe?
In the lower side, means
In the mid-axillary. First you need to identify the diaphragm with the liver. This white thing is the diaphragm. With the liver we need to identify, and we need to trace downwards in the mid-axillary line to see the Morrison's pouch, and we are checking for any fluid over here, that is free fluid over here.
This is the free fluid that we see in between the liver and the kidneys. And this is regarding the ectopic pregnancy. So we have to suspect an ectopic pregnancy if there is a positive beta HCG and if there is no and there is no uterine pregnancy seen. So if we get a patient with positive beta HCG, we have to see the value of the beta HCG. Whether it is more than 1500, then we can use transvaginal, or more than 3000, it is transabdominal. So if it is below discriminatory, then we have to repeat the 48 to 72 hours the value of beta HCG. And if it is positive beta HCG, look for intrauterine pregnancy. If it is found, then we have no issues, that is normal pregnancy. If it is not found, then we have to suspect the ectopic pregnancy. So and if there is free fluid, we have to suspect ruptured ectopic. And in normal pregnancy also there will be heterotopic pregnancy, that is in IVF we have one will be in uterus and other will be in ectopic. So for that also we have to see whether there is any risk, and if it is there, look for adnexal mass, then also we have to suspect an ectopic pregnancy.
So what all things are we looking in case of an ectopic screening?
Uterus we can see whether there is uterine, there is sac is seen or not.
So if it is normal pregnancy, you will see the uterus, and little bit towards the exterior we will be seeing a sac. So within 4 to 5 weeks what will come? Gestational sac will come. Then within 5 to 6 weeks
yolk sac.
Yolk sac will come inside. So if it is this is the gestational sac, a yolk sac will come inside, and after 6 weeks we will see a fetal pole. Okay, so that is intrauterine. If it is an ectopic pregnancy, we will be seeing anything in the adnexa, and if we are seeing any free fluid in the pelvic region, we will have to suspect an ectopic pregnancy.
And this is like pleural effusion, that is collapsed lung and pleural fluid.
So pleural effusion, how will you check pleural effusion?
Pleural effusion we have to see whether first the Morrison pouch we will see and trace upwards.
So we need to use the curved probe. So this view is with the curved probe. So as we look for the Morrison's pouch, we need to extend it upwards with the curved probe, keeping it as vertically pointing. The pointer should be towards the head end, and we need to trace upwards. Okay. So how will you, where will you keep the probe in case of checking for the splenorenal angle?
It is little bit high above.
High and posterior. So here we told mid axillary line. Here we will have to check in the posterior axillary line, because here it will be little bit posterior. Okay. So this is only with the curvilinear probe. How to see pleural effusion. Rest of the things, the
Pneumothorax will be seen with straight probe.
Can you show the first slide? First slide where you. Yeah. So in order to see the pneumothorax, we need to use the linear probe pointing upwards, and we will have to check from up down like this. From the below the clavicle towards the axilla, we need to trace. By keeping the pointer upwards, we need to trace like this. Okay. And what all things are we checking in that?
Lung sliding can be seen, B lines, whether there is any edema.
So can you explain them what is lung sliding?
Yeah, lung sliding we can see like, I have a slide for it.
Yeah.
So this is the chest wall we will see. This is the view we see with the curvilinear probe. This is a pleural line, this white line. So we are seeing whether
this
it is
white line is the pleural line. Okay.
So we will be seeing whether it is moving with respiration, like to and fro motion will be there or not.
So these are the intercostal muscles, and this lung will be sliding over it like this. That is normal lung sliding. Here this black thing what you see in this area is what?
Rib shadows.
Rib shadow. So it is looking like a bat wing. So this is a normal appearance. Normal appearance, there will be a bat wing. Okay. And what is lung rockets?
Lung rockets are artifacts in that. That is like, it will be like white white lines, hyperintense lines from the pleural line to down.
Okay. So when we are looking at this one, you will be seeing some small lines like this. What are these lines?
A lines.
A lines. That means these are actually the shadow of the pleural line. This is A line. So sometimes you will be seeing like small rocket like beam lights falling down like this. And if you are seeing that these rockets are stopping at the one A line, then that is not significant. Okay. If it is stopping with the this thing. If it is extending till down, then they are called as lung rockets. Lung rockets are B profile, B lines. Okay.
This is a B line.
So it is extending till down. Okay.
Then next is for aorta.
Then we'll have to look for if pneumothorax. What we'll be seeing, that lung sliding won't be there in case of pneumothorax.
And if you put in M mode, we can see barcode sign. Usually it will be seashore sign. And this is for screening of aorta. That is.
And one more thing. So what is the? Can you tell them what is the barcode? What is seashore?
Barcode and seashore is. So there will be lung movements. So the in normal lung there will be seashore sign. So this is a normal lung moving area. This is shore sign. This is shore, and this is sea. So this is the normal lung movement area.
So
and this
since lungs is moving, it will be shown as grains as we see in case of television. So this is the shore and that is the sea. Okay.
So if there is pneumothorax, there will be only this barcode, these lines will be there. So it is known as a barcode sign.
That means lungs is not moving because of pneumothorax. Okay.
And there will be lung point which is specific for pneumothorax. That is when we are seeing in this view, in one point the lung will be, there will be lung sliding. Here there will be lung sliding. So it is a lung point which is specific for pneumothorax.
Okay. So if we don't have a curved probe and if we are looking with the straight probe, and if there is an effusion, you will be seeing this black fluid over this area. Between the lung and the intercostal muscle, you will be seeing fluid like this. That is called as quad sign. It will be looking like a quadrangle. Okay. So, so lungs, what all things will you look?
Mainly pneumothorax and any pulmonary edema, B lines.
Yeah, so any B lines are lung rockets we will be seeing. We will be looking
sliding
for lung sliding and also
lung
effusion we will be checking. And one more thing is there, that is called as lung pulse. Lung pulse is mainly, instead of we seeing the sliding, we will be seeing some pulsatile motion. Especially that will be seen if the patient was intubated wrongly. Especially we have intubated to the esophagus and something. We won't be seeing that lung sliding because patient is intubated to the esophagus. Instead of lung sliding, the heart will be pumping here. So because of that, we will be seeing little bit of movement over here. So that is called as a lung pulse. That doesn't mean patient. That means patient we have intubated to a wrong position. Okay.
And this is the aorta screening that we will see at the below the xiphisternum. So here this will be the aorta.
Where will you keep the probe? Aorta screening.
Above the umbilicus.
So either you can use the small echo probe. Echo probe you will be keeping in the midline, and you will be tracing. You will be keeping the pointer towards which direction?
If longitudinal, we can do a short axis.
No, IVC we will be pointing it upwards. In order to see the aorta, we will have to direct towards the right side. Towards the right side and go from up to down. So first identify the aorta. We will be seeing the spinal muscles behind that, spinal cord behind that, and we'll have to trace downwards. Okay. So you can show.
And this is the aorta. We can, as already told, we can see with the that round. It will be very clear round and thick walled, and it will be pulsatile. And if we can put color also, we can identify the aorta.
And size you can measure with the measurement probe. We can measure the size, and any size within 3 centimeters normal, and anything more than 5 to 7 requires surgical repair.
So here we can find out any aneurysm is there. While tracing, we can see any aneurysms.
Okay. Then ectopic DVT.
For femoral, and we can see where saphenofemoral junction, femoral, and
so for checking DVT, we need to keep the position in keep the patient in a frog leg position.
First.
Okay. So here we will have to keep the patient's leg in a frog leg position. So just imagine this is the patient, and we will be using what probe to look for DVT?
Echo.
Linear probe. Linear probe is the one which we use for putting the vessel. So we will keep the linear probe horizontally like this, and we will be checking for the femoral vein. We will be mostly checking for the compressibility. If we have the color Doppler facility with us, then we can put on the Doppler and see. So in order to differentiate between an artery and a vein, if the color is changing from blue to orange continuously, then that means it is artery. If it is showing a fixed color, either a blue or because the color will depend on the flow towards the probe. So if we are seeing only one single color, then that means it will be vein. Okay. So we can see the compressibility of the vein. So usually it will be less than 1.4 and all, normal size. So we can compress and see if it is compressible. It might not be DVT probably. Okay. So that is all about rush, right? So we have discussed about heart, high mapped heart, IVC, Morrison's pouch,
aorta, pneumothorax or pulmonary, and then ectopic pregnancy DVT.
Okay. Anything else?
Nothing.
Okay.
Thank you.